review real quick. Your medications are the aspirin, the gabapentin, and the pantoprazole, and that's it. Protonix is your pantoprazole. Protonix is an acid blocker.
Yeah, once in a while I have little acid reflux, so maybe once every 2 weeks I'll take a pill for that.
Okay.
Well, it's time. It's October of...
Yeah. And the gabapentin, you still take that?
Yeah, every night.
And that's for...
Headaches from the eye injury.
Okay. And then the aspirin, and that's all you're taking?
Right.
Okay. Yeah, so go ahead.
Okay, well, it's October of 2018. The white blood cell count has shot up from 77 to 102, and these lymph nodes are gigantic on the left ear and left shoulder. The swelling is extremely alarming, truly alarming. Hemoglobin is 13.7. Platelets are 132. These are not alarming numbers, but to go from 77 to 102 white blood cell count is an indication that treatment is now at hand. Blood cancer is not a hereditary etiology. My B cells mutated their DNA, and gene replacement therapy is not going to be happening. But morbidity is, the prognosis is what we're going to talk about here with Dr. Schatz.
Yeah, well, what we're going to talk about is the treatment options. Okay? This is, you're a previously untreated patient for this. You've been on
10
observation
years.
for a decade. And, but at this point, I think there's a couple of indications for treatment. The main one being that the lymph nodes are progressing a little more rapidly now, and in a location where you can notice them and feel them. And I think that's causing some symptoms in that area, and I think that's likely to get worse. And your white count which was gradually going up little by little, it did jump up a little more quickly now. That by itself is not a indication for treatment, but I think those two things together tell us that treatment time has come for you. Fortunately, your hemoglobin, your platelets remain in good shape going into treatment. But I do think treatment time has come, and I think there's a couple of main options that I would consider at this point. Okay, and there's two different approaches that we could think about taking, and either of them I think are quite reasonable. One would be the one you already mentioned, that you had an association with someone who knew the guy who developed this drug, is ibrutinib. We can consider ibrutinib in you as a first-line treatment, as something that would be a gentle treatment that would be just a pill that you would take every day, and it would, in most patients who get on ibrutinib with this disease, they see their disease come under control over a period of a few weeks. Usually there's actually an initial rise in the white blood cells because the ibrutinib tends to have an effect of making the cells that are in the lymph nodes less sticky, and they actually spill out into the blood. But at the same time, they're not growing and dividing as much, and with time, actually everything shrinks away, and the white count comes down closer to normal. And,
wow.
And the blood counts should generally remain, in your case, remain.
Oh, that's beautiful.
Shape. So that's an option you can consider. And the good sides of that are that it's gentle, it's just a pill. You get on it and you keep taking the pill as long as you're not having side effects from the pill, which you can, and you're not, and it's still controlling the disease. Okay? And it is a very expensive pill, generally covered by insurance, but there may be co-payments that's hard to predict what that might be. For an
So, but
individual.
at this moment, there's no drastic infusion therapy necessary. There's no need for considering any of these drastic.
Well, that's the other option to discuss. Okay, the other option would be a course of chemotherapy, and because you're in very good shape otherwise, with good counts and a good what we call performance status,
Performance status.
meaning that you're strong and you take care of yourself and you're
Ride
athletic,
the bicycle, lift.
bicycle, etc. You can withstand a treatment which is considered the best frontline chemotherapy, which is called FCR.
Hadn't heard of that.
And that's a combination of 3 different drugs. 2 of them chemotherapy, one of them a monoclonal antibody called rituximab.
Monoclonal rituximab. Okay.
Rituximab, cyclophosphamide, and
F. Whatever. Okay.
I'm blanking on it.
Well, I always blank out myself. But the FCR, I wouldn't mind. But that's going to lose my hair. I'm going to lose hair.
You generally lose your hair with the FCR. It's given every 3 weeks. You get it 2 days in a row every 3 weeks. It's chemotherapy. So
Sure.
It suppresses your counts. It makes you so that you have may make the blood counts go temporarily low. It'll make the white count go low so that you have to be careful about infections while you're getting it.
Yeah.
And when you're done with it, your counts come back. And if the therapy works like we want it to, then the advantage of that is that it puts the disease into a remission, and you don't have to take any therapy for a period that will often last years, where the disease is in a remission.
I'm ready. But it's guaranteed that I will lose my hair.
Not guaranteed, but most people
Yeah.
will see it thin, and sometimes to the point where they just shave it off, and sometimes it falls out completely.
Yeah. If you were me, would you go with the FCR?
Probably I would. And the reason the FCR is an attractive option is that although there's a short-term period of having to go through the inconvenience and the side effects of chemotherapy, there is the strong potential for a long period after that of disease being under control and not requiring any management.
Yeah, let's do it.
And we always still have the ibrutinib available as the next line of treatment for a few years from now. If it comes, it will eventually come back again, and then we use the ibrutinib the next time. And by then you'll be, maybe 80. If things go well, you might get a nice, strong response to this, and it might be you're 80 before we have to deal with this again.
Yeah. Well, I've heard good things about the FCR, actually, so I don't have any objection to losing my hair.
Okay.
So there is 100% likelihood that the hair will fall out.
Not 100. Not 100. It's
All right.
pretty strong, though. There's always the outlying patient who goes through chemo without losing their hair. So it's never 100%, but it's pretty highly likely.
Okay. I'm sold. Do they do that at the 97th Avenue and Kendall Drive? Or
Yeah. Yeah, we can do that in Kendall.
or should I come here?
Fludarabine. I don't know why I blanked out on that name. Fludarabine is the F. Okay? Cyclophosphamide is the C. Rituximab is the R.
Right. Yeah, I've read a lot about rituximab.
So
So
that's
the F is
fludarabine.
F U.
FLUDARABINE.
Okay. Fludarabine.
Right? And then cyclophosphamide.
Cyclophosphamide.
is the C, and the
I had organic chemistry, so I'm diagramming the bends. I'm
Yeah.
trying to think of
you
the
look up the structure online if you
structure. Yeah.
play with the molecule if you want.
Yeah.
And then rituximab, of course, is a monoclonal antibody against CD20, which is found on your tumor cells. It's also found on normal B cells, but it tends to synergize together with the chemo, make the chemo work even better. Wow. And we often see a strong response. So let me just put this in here.
Yeah, it's tempting to just take the pill and have an easy thing, but I think the FCR is what I want to do.
Okay.
Good.
Okay.